I'm going to talk about non-contrast techniques, which is a little bit against the theme so far, but I think you'll see there are some pretty good reasons for doing this. You've already heard about contrast agents. There's no question that they are the preferred technique currently for MR angiography. I don't need to go through all the great reasons for using them, and we use them all the time. However, there are some motivations for non-contrast techniques. Now, the deposition of gadolinium is still a consideration. I think different groups have different approaches about this. Some feel it's more of an issue than others. But one issue that it's hard to argue about is cost, that there is a cost for giving contrast agents, and when you add up the cost of the agent and the injection apparatus, and we have to do a point of care testing, it can come up to as much as $100 to $200 per patient. So with the declining reimbursements, we'd like to save some money. We have issues where there are technical failures with contrast, and currently we have 4 hospitals. We may soon have 14 hospitals, and it's very difficult to maintain the same level of technical expertise among all the technologists performing these studies. So we want something that can work everywhere equally, and with peripheral contrast enhanced MRA, for instance, that's difficult to achieve. There are a number of different non-enhanced techniques available. They have different mechanisms with regard to being flow dependent or flow independent. Some use fast spin echo readouts, some use flash readouts, some use true FISP or balanced steady state free precession. And then you can have subtractive and non-subtractive techniques, and all of these in certain settings have proven to have some value. Now, the old time of flight technique, I think this slide is modified from one that's about 20 years old. We still use it, which is shocking to me. I don't think we should be using it, but I think it's sort of just a lack of attention that's caused this to happen. 2D techniques still used by some people in the carotids. 3D routinely used. It's still the preferred technique for intracranial MRA. And in one case, you get very good flow enhancement even with slow flow. In the other case, you get very good spatial resolution. So 3D time of flight, you can get very thin slices, high signal to noise. 2D time of flight is better for slow flow, and we can see a couple of examples of this. This is a severe stenosis of the internal carotid artery, and what you can see is that the this is the 2D time of flight showing flow voids, which is a non-specific indicator of severe stenosis. Better shown on the 3D time of flight, which is less sensitive to flow-related dephasing. On the other hand, when you have a string sign here, a critical stenosis of the internal carotid, you really can't see it. It looks occluded on 3D time of flight, but on 2D time of flight, we can see it. But even with that, compared to the contrast exams you've seen, this is very poor image quality. These techniques tend to be quite sensitive to motion and are quite time-consuming. So the strengths of time of flight, very simple, widely available. Actually works quite well, especially at 3 Tesla for intracranial imaging, but it's very sensitive to flow patterns, sensitive to dephasing with severe stenoses, and I think the biggest problem is they're quite sensitive to motion. So you can use them in the intracranial circulation, but really in the body they're not good. So a big advance was the use of inflow-based 3D techniques, and this is using a balanced steady-state free precession readout. You apply an inversion region across the area of interest that suppresses the blood flow and allow a time of about 1 second for the fresh blood to flow in, and you get really nice image quality either using navigator techniques for free breathing or respiratory belts. So this is proven to be a very accurate technique. We use it all the time. In some cases it actually outperforms the contrast techniques because, for instance, you can see the intracranial vessels here, but even with a time-resolved contrast-enhanced 3D exam, there's such rapid filling of the renal parenchyma, enhancement of the renal parenchyma, it's tough to distinguish the intrarenal branches. Another example, contrast-enhanced MRA showing a severe stenosis of the proximal left renal artery, and you can see that very nicely with the navigator techniques. Another approach is spin labeling MR, which is something that most of us don't use very much unless you're involved in the functional brain imaging field. People use spin labeling techniques to look at brain perfusion. But you can use the same techniques for MR angiography, and this is work from Dr. Kotzigler in my group, where he applies a tagging region to the carotids and then does a 3D acquisition. And it's a subtractive technique, almost like DSA. In one case, you suppress the blood signal. The other, you don't. You subtract them. And the image quality looks very much like a very high-resolution contrast-enhanced exam. So I think for carotids, this has a lot of potential. Now, it's a subtractive technique, so you don't really want a lot of motion, so maybe in the abdomen it wouldn't be so good. But in the carotids, intracranial circulation looks very promising. This is work from the Cedars group, the flow-sensitive dephasing technique, where you acquire 2 3D acquisitions, in which one of which you suppress the blood signal on the basis of sensitivity to flow. You subtract, and you get really high-resolution images. Here shown for hand imaging. It's got some potential as well, for instance, in the legs, especially for the infrapopliteal region, and that's coming along very nicely. Then the gated subtractive fast spin echo approach, where you acquire a diastolic acquisition where the blood is flowing slowly. On a fast spin echo image, we'll have higher signal. On a systolic acquisition, it's lower signal, you subtract, and you get very nice images, as shown here, that can be competitive with, for instance, CT angiography. Dr. Miyazaki really pioneered this work, and it's used at a lot of sites available commercially. And several studies have reported excellent results. Our own experience has been that this is a very tricky technique to use. We have not had consistent results, and we don't use it anymore. So this frustration led to the development of the KISS technique, quiescent inflow. We actually call it slice selective imaging now. And this is a little bit like time of flight in the sense of it's a series of 2-dimensional slices, but it's using a balanced steady-state free precession readout preceded by a saturation or inversion pulse. And you can do tracking venous saturation, and it's a very fast technique. You acquire 1 slice per heartbeat, so you can image the entire peripheral vasculature in about 7 minutes, and now that we're starting to use multiband techniques, that's reduced to about 2 to 3 minutes. So it's really competitive with contrast exams in terms of speed and in terms of quality. Here's a KISS exam. This is a contrast exam, and really tough to tell the difference. We don't require any scout with this technique. It's its own scout. There's no change in imaging parameters, so the tech literally just pushes a button and the exam is run. And short scan times, very resistant to patient motion. So on a 3D exam, if the patient moves, if you use subtraction, you can run into difficulty. Dr. Liner's Dixon technique, I think, has a huge advantage in that regard because it doesn't require subtraction. And also, unlike some of the other non-contrasting techniques, is insensitive to arrhythmias. This has been validated at a number of field strengths by a number of sites and found to be essentially equivalent to contrast exam in the peripheral arteries. Some examples of where this can be useful: patients with poor renal function. If you use this as your scout and then you have a technical problem with the contrast exam, you have this to fall back on. So in this case, the patient moved. We had poor subtraction in the left thigh, and yet the KISS exam is diagnostic. Comparing CTA to KISS, I think there's going to be a presentation by another group later this week, and I think KISS actually outperforms CTA in many regards, even though CTA is what the vascular surgeons use most of the time. So here, a patient with a lot of vascular calcifications, common in diabetics, common in some of the older folks, and it's very hard to interpret the more distal vessels even with multiplanar reconstructions, but with KISS, no problem at all seeing these bilateral SFA occlusions. But this is a problem too. So we like to see calcifications if you're planning to do a percutaneous intervention, either a TAVR procedure or just putting in a stent. Very hard to access a densely calcified vessel, and you don't see them with MR. So this is a KISS MRA showing extensive vascular disease. This is a CTA showing extensive calcification. You wouldn't really want to try to do a percutaneous procedure there. And this is a Petra ultra-short echo proton density weighted scan with flipped contrast, and you can see perfectly well as the CTA the calcifications. So we're basically using this technique equivalently to CT to see calcifications. Another example, dense calcifications, hard to interpret the CTA. KISS, no problem at all. Contrast enhanced MRA, essentially equivalent results showing this left SFA occlusion, but you can't see the calcifications. However, when you do in this case, we are using a proton density weighted radial vibe sequence. If you look, essentially point by point, equal demonstration of calcification. So I think this is no longer an issue, at least for the peripheral arteries. We can demonstrate calcifications equivalently to CT. Now, sometimes non-enhanced can actually outperform contrast. Here's an example of a twist study, very nice image quality, a little bit funny looking vessel here, mild stenosis, relatively young individual. We don't really expect PAD, but on the KISS exam, we see a little bit of high signal, which indicates something odd going on like hemorrhage. So we did additional imaging, and you can see this intramural hemorrhage, and this patient has cystic adventitial disease, which we didn't really suspect just from the conscious exam. Here, an aneurysm holding up the passage of contrast. Even though we did a good timing bolus, we don't see the iliac vessels. The SCOUT KISS exam shows those very nicely. We can also do venography. I know Ferromoxil is a spectacular technique for venography, but this costs about $600 less in terms of contrast. And this exam, we simply do the KISS technique, flip the SAT pulse to the other side, and gate every other beat, and you get very nice image quality. We've switched now from Cartesian to radial for most of our work because, as you can see, radial is much less sensitive to motion. It gives you much more flexibility. We get excellent demonstration, for instance, in a single breath hold of the pulmonary arteries and veins. Same with navigator free breathing techniques. So we're starting to investigate this, for instance, for patients with pulmonary embolism as planning for pulmonary vein isolation. We can do selective angiography, for instance, and I'll speak about this later this week, where we only image a particular vessel using arterial spin labeling pulses. And we can see coronaries very nicely, better than you can with a conscious enhanced MRA. But there are a lot of situations where conscious exams are better when you don't have these non-enhanced techniques, and that's often the case. Patients can't cooperate, severe arrhythmias, implants, or as a particular example. Here's an example, nice looking, normal, non-enhanced MRA, and yet there's a hemangioma that we missed entirely. So that is a definite problem. Then implants, conscious enhanced exams aren't too bad with the short echoes, but the KISS exam with the balanced steady state free precession, lots of artifacts. We get around this now using a flash readout instead of this, and we'll talk about that later this week. So lots of examples of MRA techniques. You can do it with contrast, I think, very conveniently, but more and more commercial techniques are becoming available to allow it without contrast. Although contrast is the dominant technique, non-enhanced techniques will be used more and more because of their convenience and lower cost. And I think the main issue is just to have the vendors offer these techniques in a robust way and that we get the clinical validation studies done. Thanks very much. That's all I have to say.